Assalamu alaikum. I am Dr. Matiullah Khan. I am consultant endocrinologist at Shifa International Hospital. Today, I will be talking about pheochromocytoma and paraganglioma. This is considered one of the most difficult topics of endocrinology, but I will try to make it very simple and will talk about the approach to diagnosis and management of pheochromocytoma and paraganglioma. Let's start with this basic knowledge of our anatomy, embryology, and then move on to the clinical aspects. So, what is a paraganglia? So, these are a group of neuroendocrine cells that migrate during embryonic development with components of parasympathetic and sympathetic ganglia. Okay, so the definition of pheochromocytoma, they are chromaffin tumors originated in the adrenal medulla. They may produce catecholamines such as epinephrine and or norepinephrine, predisposing to cardiovascular disease and other complications. And what is paragangliomas? Paragangliomas are tumors that arise from these extra adrenal chromaffin cells and can originate either in the parasympathetic or sympathetic ganglia. We talked about these paraganglias when they have a tumor that is called paraganglioma. We are more concerned with the sympathetic paragangliomas, and they arise from thoracic, abdominal, or pelvic origins. So they usually produce norepinephrine, and that norepinephrine is then converted into its stable metabolite, that is normetanephrine. The clinical manifestations. So the pheochromocytoma patient or paraganglioma patient may have multiple symptoms and they may occur episodically. Usually the patients have headache, palpitations, sweating. So headache is in around 60 to 90% of the patients, palpitation in around 50 to 70%, and diaphoresis in 55 to 75. They may have all other symptoms as well, but anxiety and panic is very important, and we should also appreciate that not all patients of pheo and PGL are hypertensive. In fact, around 50 to 60% of patients have sustained hypertension and only 30% have paroxysmal hypertension. And the patient may also have orthostatic hypotension. So the critical first step in making the diagnosis is to suspect the presence of a tumor. Now, this is from the guidelines of the pheo PGL that was published in JCEM. So who should you evaluate for pheo paraganglioma? Thus, the first group of patients should be those who have paroxysmal constellation of symptoms or signs or episodic spells strongly suggestive of catecholamine excess. That means the patient may have palpitation, sweating, anxiety, panic attack, elevations in blood pressure, headache, pallor. All these patients should be considered for evaluation of pheo PGL. Number two, when the patient has the precipitation of these symptoms by a culprit medication or maneuver, like by the induction of anesthesia or by the beta blockers, steroids, SSRIs, or sympathomimetics, then we should strongly consider the patient for evaluation of pheo PGL. And another group of patients who have incidentaloma, the adrenal incidentaloma, incidentally discovered adrenal masses, especially when the Hounsfield units are more than 10 on CT scan, should be considered for evaluation for pheo PGL. Known or suspected hereditary predisposition, and also someone who has a past history of pheo PGL. Let's talk about embryology. Now, we know that adrenal gland has the adrenal cortex and medulla. Adrenal cortex will be arising from mesenchyma, and medulla is arising from neural tube. So neural crest cells, so the cortex is basically from the mesothelial cells of the fetal adrenal cortex that is being formed from mesothelial cells. But the neural crest cells will migrate ventrally and form the sympathetic ganglia and also the adrenal medulla. This adrenal medulla and adrenal cortex will form the fetal adrenal gland. What are the pheochromocytomas and paragangliomas? We know that we know about the sympathetic chain, that is moving all around from the neck to the thorax, abdomen, and pelvis. And this sympathetic chain has these paraganglias. In these paraganglias, a tumor may arise that is called paraganglioma. While in the adrenal medulla, if a tumor arises, that is the pheochromocytoma. Let's talk about these two patients and understand. 21-year-old female with a past medical history of anxiety, depression, and she is on venlafaxine, and she complains of fatigue, dizziness, lightheadedness, and sweating. She has a 2 years history of progressively worsening sweating, anxiety, palpitations, and the symptoms are unpredictable and occur episodically, and there is escalating symptoms. So she has many social school stressors, and the clinic vitals are BP is normal and pulse is 116 per minute. Could this patient have a pheo or a paraganglioma? What is your pretest probability? Moving to the second case, a 64-year-old man with a past medical history of anxiety, depression, hypertension. Patient is on imipramine, losartan, amlodipine, and the chief complaint is worsening anxiety, palpitation, and BP. So 3 months of worsening anxiety, palpitation, and a blood pressure of 178 by 90. And these also occur episodic and unpredictable. And new work-related stress and travel. And the blood pressure in the clinic is 164 by 88 and pulse of 88 per minute. Could this patient have POPGL? What is your pretest probability? We will come back to these cases. Now, if we do the labs of the first patient, and frankly, in the first patient, I have a very high pretest probability because of the episodic symptoms and they are worsening and sweating, anxiety, palpitation, although the blood pressure is normal. While in the second patient, we commonly encounter such patients who have anxiety, depression, and hypertension. This may be primary hypertension, and the patient may have anxiety and depression and is on these drugs. So a bit low to medium pretest probability in the second patient and high probability in the first patient. So in the labs, the plasma metanephrine is normal and plasma normetanephrine is elevated, and it is 5 to 6 times elevated. So from 0.9, it is elevated to 5 nanomole per liter. If we do further testing, which are not actually required, the 24-hour normetanephrine is also in 6,000 range, which is many folds elevated. So does this patient have POPGL? In other words, what is the post-test probability? This has a very high chance to be a pheo or paraganglioma. Talking about the second patient, the plasma metanephrine and normetanephrine are slightly elevated, 0.71, and the normal is less than 0.5. While the normetanephrine is 1.2, normal was 0.9. So slight elevation. Does this patient have a POPGL? Very less likely. Okay, so let's talk about the catecholamine synthesis and metabolism. We will talk about the case later on again. So we should know that tyrosine is the backbone. So everything is made from tyrosine. Tyrosine is converted to levodopa, that is converted into dopamine, norepinephrine, and that norepinephrine is converted to epinephrine. Adrenal medulla is all the machinery to form the epinephrine because it has the PNMT enzyme. So in the peripheral, in the extra-adrenal chromaffin cells, the sympathetic nervous system, we can make up to norepinephrine, but not epinephrine because there is because the sympathetic nervous system does not have this enzyme PNMT. So tyrosine to levodopa to dopamine and then norepinephrine, this occurs in both adrenal medulla and in the paraganglias, which are the sympathetic nervous system. But after that, the PNMT is only in the adrenal medulla, so epinephrine will only be made in the adrenal medulla. So this has importance in the clinic. We will discuss about that. But just understand that this dopamine, norepinephrine, and epinephrine, they are episodically produced and very difficult to measure. These are called the catecholamines. But these this norepinephrine and epinephrine are metabolized to its stable uh, product, which is normetanephrine and metanephrine respectively. And these are measured and they are very stable and can be measured at any point of time. So whenever the patient has high normetanephrine, that means ke norepinephrine se hi sab kuch aa raha hoga. And if the patient has metanephrine, that will come from epinephrine. So we should understand one thing, that as the presence of PNMT is only in the adrenal medulla, therefore epinephrine भी adrenal medulla में ही बनता है, तो metanephrine जब भी ज़्यादा हो, this is coming from adrenal medulla. While if the patient has raised normetanephrine only, there is high chance that the patient have paragangliomas, but it is still possible because in 20% of the cases, the normetanephrine can arise from adrenal medulla. Then these are then converted into VMA and excreted in the urine. So again, in the guideline, the question is which test should be done? So plasma-free metanephrine is the diagnostic test of choice. And it should be elevated 4 folds, 3 folds to comment on it that this is most likely a Pheo or a paraganglioma. And the sensitivity and specificity is high, especially the sensitivity is almost 100%, but specificity is 85 to 90%. You can also do 24-hour urinary metanephrine, but that is cumbersome and difficult. So the test of choice will be plasma-free metanephrine, and it should be markedly elevated. In someone, especially who has symptomatic Pheo, this patient will have 6-fold, 5-fold elevated metanephrines. So if the patient has a normal value, this patient does not have Pheo. This has a very high negative predictive value. But if the patient has slightly elevated metanephrines, this patient may not have a Pheo. You cannot say that any patient who has slight elevated metanephrines has a Pheo because of the false positivity in around 10 to 15% of individuals. So especially when it is slightly elevated. But if it is markedly elevated, then the positive predictive value increases. So let's talk about this. Here is the circulation. Here you can see the norepinephrine released from the sympathetic nervous system. And this is the adrenal medulla. 90% of the norepinephrine is produced by the sympathetic nervous system, and around 10% is released from adrenal medulla. Now, this norepinephrine is converted into its normetanephrine, and in both the sympathetic nervous system and adrenal medulla. And in the circulation, about 75% of the normetanephrine is due to sympathetic nervous system producing it, while the remaining 25% is due to the adrenal medulla producing it. But when we talk about epinephrine, almost 100% of it is produced by adrenal medulla. Yes, it does go to the non-neuronal cells and produce metanephrine in around 10% of the cases. But we should understand majority of the metanephrines come from adrenal medulla, and majority of the normetanephrine come from the sympathetic nervous system. When both of them are elevated, it's most likely Pheo, that's adrenal medulla. When only normetanephrine is elevated, it's most likely sympathetic nervous system paraganglioma. Okay, so let's talk about it. Now, this is either a sympathetic neuron or an adrenal medullary cell. And this is the post-synaptic neuron or end organ. Here you can see tyrosine becoming L-dopa, and that will produce dopamine, producing norepinephrine and epinephrine. This norepinephrine, epinephrine are the catecholamines, and we understand that sympathomimetics can increase them and result in a false positive result. So any sympathetic nervous system activity like pain, anxiety, stress, upright posture, or illness can result in the increased sympathomimetics that can falsely give a raised norepinephrine or epinephrine that in other words means normetanephrine and metanephrines. And we should also understand that they are basically the norepinephrine and epinephrine are metabolized by monoamine oxidase, and if the patient is on monoamine oxidase inhibitor, that can also falsely increase, but this is not usually used. Okay, so these norepinephrine and epinephrine will go out, and then almost 95% or more are taken up again by these sympathetic neuron or adrenal medullary cell by the reuptake transporter. So any drug that will act on this reuptake transporter, like the SSRI, SNRI, these antidepressants, cocaine, they will markedly elevate the circulatory norepinephrine and epinephrine, which will then obviously become normetanephrine and metanephrine. This is very important because this will result in a false positive result. So here we are talking about the false positives. So the first one was sympathetic nervous system activity, any pain, anxiety, upright posture, illness, sympathomimetics will directly produce the catecholamines, then the monoamine oxidase inhibitor, and then the norepinephrine, epinephrine reuptake inhibitors, SSRIs, cocaine, antidepressants. Very rarely the alpha adrenergic or the calcium channel blocker or beta blockers. So let's summarize the false positives. Number one, sympathoadrenergic activity, pain, anxiety, stress, critical illness, and even non-supine posture. This can result in increased catecholamines. Medications, either by assay interference, which is not a major issue when we use the modern assays, or by physiologic interference. We saw that physiologic interference is by many drugs like norepinephrine, epinephrine, dopamine infusions in a critical illness patient, or if there is a tricyclic antidepressant used or reuptake inhibitors used, cocaine or monoamine oxidase inhibitor. Severe renal insufficiency is also not a major issue when we use free plasma metanephrines. So now here you can see the plasma fractionated metanephrines and how much it is elevated. So twofold, threefold, fourfold, and fivefold. The true positive case, the typical symptomatic PheoPGL will be markedly elevated, usually fourfold or fivefold. Very rarely a case report will be there when it is just elevated by twofold or less than that. While a false positive will be slightly elevated, and this is due to upright posture, medications, stress, illness, anxiety, pain, sympathetic excess, and there is a slight overlap between these two. So whenever you have these slight elevations, you should again either just see whether this patient had a pretest probability, whether a high pretest probability. In that case, we can repeat it in a supine posture without any medications and not in a state of illness or stress, or we can just say that this is not Pheo. And when it is normal, we know that this is true negative. It has a very high negative predictive value. So the proposed diagnostic algorithm is evaluate the clinical likelihood and consider factors that may cause false positives, like posture, like medications, stress, illness, acute illness. All these should be ruled out, and then see whether the patient has a high likelihood or a low to medium clinical likelihood. In a high likelihood, we will just proceed to the plasma or urinary, usually the plasma, metanephrines. And if they are within the reference range, we can reassure and investigate for alternative cause of symptoms. We may repeat it if we have exceptionally high concern of the clinical likelihood, but usually when the test is within the reference range, we can rule it out. If the patient has a low or medium clinical likelihood, the first question should be, do you need to even test that patient? But when we are testing for the patient, we should discuss with the patient that there are factors that may cause false positives and that may be slightly elevated. So we are expecting the values to be substantially elevated. Because if we don't explain all these things and the patient has a slightly elevated metanephrines and we didn't have any likelihood, high likelihood, So then we will be in trouble, because then we will be keep on repeating the tests. So ऐसे लोगों में करना ही नहीं चाहिए टेस्ट जिनका लो टू मीडियम क्लिनिकल लाइक्लीहुड है, बट वी आर डूइंग इट, then we should we should be expecting a very substantial elevation. So if it is within the reference range, you can reassure and investigate alternative cause. Now let's talk about this. When the patient has a high clinical likelihood and we measured it and there was substantial elevation of fourfold elevation, in that case, the biochemical confirmation of your clinical suspicion is done. After biochemical, we always go to the radiological. That is, we have to localize the tumor with abdominal CAT scan or MRI. If abdominal tumor is identified, you don't need to do anything else and just directly go and prepare the patient for surgery. So this is the patient. The pretest probability was high, and the substantial elevations of more than fourfold. It was 5 to 6-fold. So in the post-test probability is extremely high and confirmed, kind of confirmed. Abdominal CAT scan was done, and here you can see nothing in the adrenal is appreciated. So these are the two adrenals. No adrenal masses and no extra-adrenal masses. In such cases, then you should, when there is no abdominal tumor identified, then first you should reconsider the diagnosis and false positive, and also consider imaging for extra abdominal paragangliomas. And in this case, here you can see this 2 by 2.7 centimeter paravertebral mass, and also this one. So in the left AV groove. So 2 PGLs, and this is pathognomic SDHB mutation that we will talk later. Now, if the patient has minor elevations, high likelihood, but minor elevations, less than 2-fold upper limit of normal, we can reconsider medication effect or other potential false positive and repeat in the absence of these factors. And also we can either say that this the Pheo or PGL is excluded, because such high symptoms, Pheo PGL will have markedly elevated metanephrites. Now, this is another scenario with low to medium clinical likelihood, and we should not have tested, but now we have tested, and it is substantially elevated, 2 to 4 times elevated. In this case, the biochemical confirmation of clinical suspicion, and now the tumor should be localized. Again, if the abdominal tumor is identified, prepare for surgery. If no abdominal tumor, then reconsider your diagnosis, and false positives, consider imaging for extra-adrenal. There is this common scenario when there is low to medium clinical likelihood and we do the plasma metanephrines and there is slight elevation, less than 2-fold upper limit of normal. In this case, we should reconsider potential false positive sources and consider repeating the test in the absence of these factors and just follow these patients. So this was the second patient in which basically there was low to medium suspicion and the post-test probability was also low. So the most likely diagnosis in this is false positive attributable to anxiety and or antidepressant medications. So because of the slight elevation, we should understand that the other factors are causing it. Now, peri-operative management. The goal of pre-operative medical therapy is, number one, to block the peripheral effects of catecholamine, to minimize the excessive intraoperative alpha and beta agonism that may result in end organ damage, but simultaneously minimizing the risk of post-operative hypotension. Number one step is to identify experienced surgeon and anesthesia team. Number two, we will do alpha blockade with either selective or non-selective. Selective is this doxazosin, or non-selective is phenoxybenzamine for more than 1 to 2 weeks when it is possible. And along with it, we should also do the intravascular volume expansion with salt or IV normal saline. Because catecholamines have a natriuresis effect. That's why the patient should be given IV normal saline and also given salt preoperatively. When needed, we can also add beta blocker in the patients, and in some cases also calcium channel blocker for blood pressure management. The perioperative management, there is no robust randomized controlled trial to dictate the optimal perioperative management. So one protocol is you start with doxycycline 1 to 5 mg per oral BID for 2 weeks. You start with 1 or 2 mg BID and then increase it, titrate it to the target blood pressure of systolic 100 to 120 and diastolic 60 to 80. You should avoid orthostasis. The diet should have high sodium and IV saline overnight the day before surgery. Beta blockade, we should be gentle when normal cardiac function, especially when the heart rate is less than 100. We should be more aggressive when known heart disease. As needed basis, maybe using calcium channel blocker. We need a good anesthesia team, and they should have prepared IV phentolamine, ismolol, nitroprusside whenever needed during surgery, and also even norepinephrine because of the high chance of post-operative hypotension. Now, this is patient 3, and this is interesting and a bit difficult to understand. Now, we are talking about this patient, and many of the relatives here you can see had Pheo or a PGL. So we should understand that it is inheritable Pheo PGL, and there is high genetic susceptibility. And how should we counsel this patient? Now, a pathogenic mutation in which of the following gene is most likely responsible for this family pedigree when the patient has metastatic PGL, and sporadic benign Pheo. So many members are affected by either Pheo or PGL. The answer is SDHB, succinate dehydrogenase B. Now, in 1990s, it used to be thought that Pheo is a sporadic, benign, non-familial adrenal tumor. But then we understood that along with NF1, there are VHL and MEN2, and these are well-described syndromes. That's why then we thought that mostly benign and sporadic, but 10% familial and 10% malignant, a rule of 10. But in the 2000 and after that, we understood that there were many genes, the SDH family, SDHD, SDHC, SDHA, B, THD, MAX, TMM, HIF, all these were discovered. So now we know that around 30 to 35% are inheritable, Pheo-PGL syndromes. So in the Endocrine Society guidelines, we recommend that all patients with Pheo-PGL should be engaged in shared decision-making for genetic testing. Here you can understand that von Hippel-Lindau gene is, the syndrome is caused by gene VHL. NF1 will cause neurofibromatosis. RET will result in MEN2. These are the 3 syndromes that we well know it. But then there are others as well, SDHA, B, C, D. They are resulting in PGLs. And they are associated with pituitary adenoma, GIST, RCC, and all of them are usually autosomal dominant. Now we have comprehensive genetic testing approach, which contains almost all of these genes. And in a panel, we can order these tests and understand that which gene is being involved. So this is one approach, clinical evaluation and genetic testing when it is positive. So there should be surveillance program, annual physical exam, symptom and BP assessment, annual biochemical screening by plasma metanephrines, and also imaging, maybe organ specific for VHL, RET or NF1. But when someone has SDH, so we don't know which tumor will it result in. So then we have to image from the base of skull to the pelvis with MRI every year. So this patient had this paraganglioma in someone who had a family history, the strong family history. Here you can see strong family history, but when was screened for genetic testing, had SDH and got this diagnosed. And then many other family members were also diagnosed when the screening was done in them. And even some of them developed Pheo and PGL. So the take-home messages are: prior to biochemical testing for Pheo or PGL, develop a clinical pre-test probability and identify potential factors that may cause false positives. Plasma or urinary metanephrines are appropriate and highly sensitive screening tests. True positives typically have substantial elevations of metanephrines when compared to reference range. So around 25 to 30% of Pheo-PGL can be attributed to a known inheritable genetic alteration with implications for patients and their families. An individualized approach, individualized genetic testing and surveillance plans should be considered for all patients with Pheo-PGL by a healthcare team. Thank you so much.